My talk is about management of hypertension after delivery and beyond. I have no disclosures. The objective of this talk is to provide improved understanding of hypertension and its contribution to morbidity and mortality in the postpartum period. It's also to describe the natural course of blood pressure in the postpartum period and to consider options for postpartum management of hypertension as an outpatient. I think over the past few years, there's been a lot of attention to hypertension in the press. These are from two publications, USA Today and New York Times, some of the largest circulation in the US nationally, and they all talk about the role of hypertension in maternal mortality over the past few years. It became a hot topic in the US because maternal mortality had been rising. This article talks about hypertensive disease and the crisis that was going on that is going on in the US. There's been also a lot of press related to hypertension. Some of these media figures, Beyonce, Laura Bush, are all in the media and have talked about their experience with hypertension and preeclampsia. So there's a lot of public interest in this topic. Here's a graph or a graphical picture of the world and the rates of maternal mortality in the world. You can see that in the Northern Hemisphere overall, they generally have a low rate of maternal mortality. And this is World Health Organization UNICEF data from 2017, with the highest rates in sub-Saharan Africa and you can see in other areas of the world. So it continues to be a problem. This is World Bank data of all contributions of where maternal mortality occurs. And over the past 3 decades, you can tell that from this graph that maternal mortality has improved across the world, but is still a significant issue, with the highest rates with not much improvement over this period of time in sub-Saharan Africa. There's been improvement overall across the other areas or regions of the world. If you break this down into various regions, you can see in South Asia, where India is, you've had improvement, and generally areas across the world has had improvement. But if you look at the US or North America, it's one of the few areas of the world that rates have started to go up. And there may be a number of reasons that this is occurring. Well, what is the cause of maternal mortality across the world? How much is it pregnancy related versus indirect causes? Indirect causes probably have the largest contributor, but when you look at pregnancy related causes, the 2 leading causes are hemorrhage and hypertension being the second in pregnancy related causes. In the US, you can see over the past 3 decades, we continue to have worsening rates of maternal mortality, and that may be related to higher rates of obesity, increasing mean gestational age in women putting off pregnancy until later to more advanced years. Why is the postpartum period such a concern? Well, if you look at this graph, this is US data for years 2011 to 2013 that was reported by Chien in Obstetrics and Gynecology in 2017. And you can see that over 50% of pregnancy-associated maternal mortality actually occurs in the postpartum period. And if you look at timing and frequency of these events, the highest rate per day occurs on the day of delivery, followed by the first week. So postpartum days 1 through 6. But it still persists out through the postpartum period, or 6 weeks out, and also during the first year after delivery. You can break this down into different periods and get a little bit better appreciation that only around 30% of maternal mortality occurs prior to pregnancy or prior to delivery. 17% occurs on the day of delivery, and 40% occurs during the 6-week postpartum period, followed by 13% through the rest of the year. This got recognition by the American College, and with a working group came up with suggestions on optimizing postpartum care, suggesting that we're not doing an adequate job in following patients after delivery. In their committee opinion, you can see what their recommendations. The standard is really one visit approximately 6 weeks after delivery. The American College suggested that we should actually do more visits during the postpartum period, with evaluation of blood pressure during the first 3 to 10 days after delivery, and then another follow-up 1 to 3 weeks out. I believe a lot of this was based on the data showing that the highest risk for maternal mortality actually occurred within the first 3 weeks and actually within the first 7 days after delivery. Specifically, the American College suggests that patients who should have monitoring up to 72 hours after delivery if they've had hypertension going into pregnancy or coming into their delivery, and should be seen within 7 to 10 days after delivery. In addition, all patients should receive instructions related to signs and symptoms of preeclampsia. New onset in patients with new onset postpartum hypertension, consideration should be given to administer magnesium if headaches, blurred vision, or other symptoms are consistent with severe hypertension should persist. They suggested also that medical therapy should be initiated if a systolic blood pressure was exceeded 150 or systolic or 100 milligrams of mercury diastolic. So most of us are familiar with the management antepartum, but what do we do after the patient's delivered? Most of us are relieved that the patient's delivered because we know that patients will start to get better. But what are the real risks after delivery? Do we really understand that? Our routine postpartum care involves primarily supportive care. We generally continue magnesium if the patient has severe preeclampsia or signs of severe preeclampsia for a specified period of time. And most of the institutions I've worked in have continued it for 24 hours. Some institutions use other criteria to discontinue magnesium past the 24 hours if they haven't beginning to diarrhea or their laboratories have not begun to correct. We follow labs if they were noted to be abnormal prior to delivery, and then we manage severe range blood pressures defined as 160 systolic or 110 diastolic. And then we range for postpartum follow-up. Question is, should the target blood pressure be in the postpartum period? Do we really know? Well, let's look first at postpartum readmissions. In our country, we have the Agency for Healthcare Quality Research, which is a governmental organization that actually evaluates readmissions within the hospitals within the U.S. It actually collects data from 22 states, has data on approximately 51% of U.S. residents and approximately 49% of all U.S. hospitalizations. They generally collect data from the beginning of January through October for the first 10 months, and then report their data. What's the likelihood for readmission if patient did not have hypertension during their pregnancy or during delivery? What do we know about that? Well, this report used that AHRQ data, and this group is out of Columbia University in New York City. And they noted that antenatal hypertension readmission was about 1. If patients had antenatal hypertension, the readmission rate was about 1%. In patients with no hypertension, that rate was only 0.15%. So a tenth of that of those who had prior or had hypertension during pregnancy. And this is called from data over 5 years from 2010 to 2014, involving 15 million deliveries. And they also noted that 89% essentially of readmissions occurred during the first 10 days, 9% occurred during the period between 11 to 20 days, and less than 1% occurred after that in 21 to 30 days or a month to 2 months out. The characteristics for those readmissions were really patients who were older, so 30 to 34 years of life, those on federally funded insurance called Medicaid. In the US, approximately 50% of patients who deliver are funded through the government, and the rest of people have a private insurance. It was also characteristic that the lowest income quartile had about a third of all the readmissions. This study was initiated by to look at readmissions. The premise initially was that infection was the primary cause for readmission in the postpartum period. This group was primarily responding to the Office of Management and Budget recommendation on reimbursements or rewarding or penalizing patients or organizations for readmission in the US. One large for-profit organization called Hospital Corporations of America, who has 114 hospitals, looked at their readmissions in 2007. They initially focused on infectious morbidity because they believed that was the primary cause for readmissions. They looked at compared obstetric versus non-obstetric causes. And what they found in patients who delivered vaginally, hypertension was the most common cause of readmission, whereas in cesarean sections, uterine infections were the top leading cause. But hypertension was the second leading cause in patients with cesarean section. And this frequency was around 16.4% for vaginal deliveries, 16.4 per 10,000 deliveries, or 0.1%. And then for infections was 23.9. This study also looked at the same data source from the Agency on Healthcare Quality Research, and they looked at for the period 2013 to 2014 what the contribution of hypertensive diseases were on readmission. In their data set, about 6 million deliveries, 10% of patients had hypertensive disease, or 666,000 patients out of the 6.3 had antenatal hypertension. And the readmission rate in this group was 10.6%. The primary diagnosis that during their pregnancy is given in this pie graph, with mild preeclampsia or gestational hypertension contributing to about over half, or 55%. Chronic hypertension was next at 22.5%. Patients with severe preeclampsia or superimposed preeclampsia on chronic hypertension contribute about a quarter. The risk for readmission, if you have gestational hypertension or any of these hypertensive diseases, are given on the right. So what you can see is that as your diseases progress, becomes more severe, your risk of readmission increases. And if you have chronic hypertension, your risk is about 1 in 20 to 1 in 30 for readmission. This study from the University of Pittsburgh Medical Center and McGee Women's Hospital looked at associated factors for those patients who initially presented with postpartum preeclampsia. So they did not have hypertensive disorders prior to delivery. We know that was an infrequent admission, a cause for admission based on the prior study that I discussed. They looked at their own readmissions in a 5-year period at a single center. It involved a total number of around 27,000 deliveries during that period of time. And they had only 121 admissions for delayed onset postpartum preeclampsia, or 0.45%. The median admission day was around day 7, and nobody got admitted after day 19. So it's an uncommon thing to occur, and it will, if it does appear, it usually appears before the 21st day or before 3 weeks are over. But over 10% of those who were admitted ended up going to the ICU for care. The characteristics of those who are at highest risk for this to occur were those who were older than age 35, being Black race, being obese, or undergoing a cesarean delivery. There's some other characteristics of the presentation of those patients. Most people presented because of symptoms. Some people were detected because they were either monitoring the blood pressure at home for whatever reason, or they had monitored their blood pressure. They had come back for a visit to their physician's office. The most common complaint was headaches, followed by shortness of breath. What was interesting, though, is that of those who came back with preeclampsia-like symptoms, only less than 30%, or less than 1 in 5, had an elevated protein to creatinine ratio. So this proteinuria was not a common characteristic in this group. But what was noted is that it was resource intensive. A lot of test studies and interventions were performed in this group of patients. The majority, or 82%, actually were treated with magnesium. About 50% were given antihypertensive, intravenous antihypertensives to lower their blood pressure. And over half were discharged on medication. In long-term follow-up, about a third of those patients were still on antihypertensive 6 weeks out, and at 3 months after delivery, about 1 in 5, or 20%, needed continued therapy. The takeaways from this information is the vast majority of readmissions related to hypertension are those who have had antenatal diagnosis of hypertension. Postpartum hypertension, the absence of antenatal hypertension diagnosis, is infrequent. suggesting that resource allocation should be focused on those with elevated blood pressures prior to delivery or during delivery. So what do we know about the normal course of blood pressure in the postpartum period? Is it spiking blood pressures like we see in patients presenting with preeclampsia? Or does it tend to be a little smoother in progress? This older study by Walters that was published in the Lancet is a small cohort study, primarily descriptive in nature, in looking at patients with preeclampsia hospitalized for 7 days. And at that period of time, routine hospitalization for 7 days was common. 67 women in this cohort had mild to severe preeclampsia. 22 of these patients required medical therapy. What they noted on their blood pressure monitoring is that there is a diurnal pattern of blood pressure, highest in the mid-afternoon, with elevations as high as 7 millimeters of variability. And the blood pressure increased from days 3 through 6. They hypothesized that this rise was related to postpartum diuresis or mobilization of fluid or extravascular fluid into the intravascular space. What do we know about hypertension or blood pressure after those 7 days? Well, this publication is out of University of Pennsylvania. They looked at blood pressures because they were interested in following the ACOG criteria and trying to get monitoring information. And so they had patients monitor and text their information in a remote monitoring trial. And they noted that blood pressure decrease was highest during the first 6 days or during the first week, which is consistent with what Walters showed. And then decreased and hit the nadir around 3 weeks out after delivery, consistent with what is seen for readmissions. As an aside, based on ACOG monitoring guidelines, they also reported compliance rates to see if they were doing what ACOG suggested in monitoring patients for the first 10 days. In the text-based, they had 84% compliance. In the standard care, where patients had to come in for an office visit, only 44% returned. For the 6-week postpartum visit, 69% of people continued to send in information, whereas for standard care, about only 58% showed up for that visit, which is a common problem in the US. Because of this theory that this was mobilization of fluid, this group from University of Mississippi actually looked at the use of Lasix or furosemide as a diuretic to help mobilize fluid. They did an open label randomized clinical trial looking at patients who had preeclampsia, either mild or severe, or post-preeclampsia, and randomized to either a 5 course of furosemide and potassium versus no treatment. They powered the study to 80% for a detection rate of 5 millimeters of mercury change in systolic. They noted treatment group had a lower blood pressure beginning postpartum day 2. They had a trend toward lower additional antihypertensive therapy, but they did not find a statistically significant difference in those who were treated versus not, probably because they didn't power for postpartum complication rate. So overall, they decided that overall there was no clear benefit for this treatment. So what do we know now? Blood pressure rises during the first 7 days after delivery, then falls after that, reaching its nadir 4 to 6 weeks postpartum. The changes correlate with the postpartum readmission rates for hypertension. And it's unclear if short-term therapy is beneficial to reduce complications or readmissions. So what to do? ACOG recommends monitoring for up to 72 hours, potentially as an inpatient, and then a return visit 7 to 10 days out. They suggest therapy at 150 systolic or 100 diastolic. Are we able to actually monitor? So this study did a trial looking at monitoring postpartum. Was a multi-center 5-site study in Britain using the National Health Service, self-management or daily blood pressure. And this gives a little protocol. The slides will be available after. Carnes reported this on this protocol. People were eligible if they had hypertension and were on therapy at discharge. They were randomized to standard care versus daily self-monitoring with text messaging. And this was primarily a feasibility study. They noted that self-monitoring group had lower mean blood pressures, had higher readmissions rate, probably because you were detecting it, versus those who were standard care, and that the blood pressure was lower at 6 months in those who were self-monitoring, probably because they were being treated. Limitations that people needed to have text messaging. It did show that this was a feasible protocol. This is another quality improvement study that was reported out of University of Pittsburgh, similarly trying to look at remote blood pressure monitoring using a smartphone. In their study, they showed that people were relatively compliant during the first 2 to 3 weeks, consistent with ACOG recommendation, but that compliance continued to fall out through 6 weeks postpartum. But we do know that patients are more likely to have hypertensive issues during the first 3 weeks, suggesting that this was a reasonable thing to do after delivery. So is this the right value to initiate therapy? We know that blood pressure rises around 7 to 10 millimeters after. If you use 150 systolic, patients are going to get into the severe range. So should you really start blood pressure treatment prior to at values less than 150? And if you're going to start therapy, what should you use? Should you use a diuretic such as furosemide, or should you be using something that's maybe more effective at reducing blood pressure? And what should be, and we also know dosing frequency impacts compliance. We have a fellow who's actually trying to address this question using various antihypertensives and trying to determine what blood pressure should be used to determine treatment. In 2017, the definitions of hypertension changed. I think this is in the American Heart Association 2017 recommendations, and suggests that maybe we should be using lower numbers. So what's the right decision and what's the wrong decision? Unfortunately, I don't have an answer for you. In summary, though, hypertension we know is responsible for 14% of maternal mortality worldwide, and is 7% in the US. Blood pressure increases after delivery, peaking at 7 days, suggesting that we probably need to be more aggressive in managing blood pressure in the postpartum period. But will this really reduce morbidity and mortality? That's hard to say. So thank you for your attention. I think I'm running close to the time.
Yes, you have kept the time, and thank you very much for that amazing talk, touching all the points. I don't see any questions now in the chat box. Can I ask you one question, sir?
We can have a discussion now.
Later or now?
Now itself. Pail sir, you want to make any comments?
No, I was just wondering whether we should follow starting treatment for pregnancy hypertension at 140/90 rather than 150/100, which was suggested by Dr. Chien. You referred to an attempt to bring down the threshold, But is it widely practiced? In pregnancy, we follow treating hypertension at 140/90 and above, rather than going up to 150/100.
So there's actually a study going on called CHAP in the US. It's a multi-center trial that's actually looking at management of hypertension during pregnancy. And they're essentially randomizing patients to permissive hypertension or allowing patients to run 140 to 160 versus trying to keep blood pressures below 140. This study is almost done recruiting or recently closing recruitment. So we look forward to those results. That probably will give us an answer on sort of the risks versus benefits of aggressive treatment of blood pressure versus allowing permissive hypertension, which is what the American College has currently said. Because there are competing interests. We know that people who have aggressive treatment tend to have smaller babies, but get farther on in pregnancy, so they get delivered later. But those who are allowed to have higher blood pressures tend to be delivered earlier for preeclampsia, or generally. So their gestational age is in general shorter. So we don't know the answer quite yet, but there's a study that hopefully will actually answer that should be reported out, I believe, within the next year or two.
But Dr. Chien, what is the antihypertensive of choice, the first line they use? Is it labetalol or?
In the US, labetalol has become the first line agent. I think calcium channel blockers like nifedipine is also fairly commonly used.
No, the problem that we find is that if you use labetalol over a longer period because of the beta blocker effect, whether that is also responsible for getting smaller babies, growth restriction.
Well, is it the disease or really the medication? It's hard to say at this point.
Thank you, Dr. Chien.
Have any incidents of stroke in the patients presenting with postpartum hypertension? Any cases of stroke?
For treatment, or we do see strokes after, but those, in fact, there's some research in patients who do not have chronic hypertension that pressure-induced vasodilation of cerebral vessels occurs at lower blood pressures than in those who have chronic hypertension. And that's why, I think that's why in pregnancy, there's such an aggressive move to treat people when they hit 160, whereas I think for people who have chronic hypertension, the treatment isn't, acute treatment with IV medications isn't generally started until much higher levels, like 180 to 200.
Thank you.